So this video will serve as our week two, debrief for coverage of some of the other comprehensive pieces that we talked about in week two of the PADI class. The first thing I want to talk about is the value of epinephrine in cardiac arrest. This is an ongoing piece of research for out-of-hospital cardiac arrest, and we've seen some recent changes in what the suggestion is from Heart and Stroke and the ILCOR guidelines. So the first thing I want to talk about is just the mechanism of action of epinephrine, how it works, and why we're giving it in cardiac arrest. And then we'll go on to talk about, what timing means and what does some of the more recent evidence suggest in terms of epinephrine administration. So we'll take a look at the mechanism of action of epinephrine in the patient who's experiencing cardiac arrest. So when we're giving epi in cardiac arrest, we're really looking for a couple of different things. First, we're looking for activation of our beta-1 receptors in the heart, which are going to provide us with a few different actions. Beta-1 receptors will activate intracellular signaling cascades, the first being CAMP, which is going to help with a number of things. First, we start to see an increase in contractility. So the activation of that intracellular signaling cascade is going to promote an increase in contractility, or basically our contractile units are going to contract harder. The other thing that we see is changes in conduction. So activation of those CAMP pathways are going to lead to not only an increase in conduction, so that would be the rate in which the conduction system is firing, but we actually see an increase in our conduction speed, or the dromotropy of the ventricle or the conduction is going to be higher. So conduction speed will be quicker. So we'll get an increase in rate. We'll also see an increase in contractility, two things that we know are going to promote an increase in cardiac output. The other piece, or the big piece that we see, is the mechanism of action of epinephrine at our alpha-1 receptors. So epinephrine is going to bind to alpha-1 receptors in the periphery to cause an increase in contractility. So we can see here the vessel is going to get smaller. And the benefit of that is we start to see constriction in the areas where we want to push blood away from. So think about the cutaneous vessels in the skin, our peripheral vessels, our skeletal muscles. We want to push some blood away from there, or the vessels in the splanchnic system. So that would be the vessels that are supplying the mesentery with a lot of their blood supply. So we're going to push blood out of some of our peripheral areas, or the areas that don't necessarily need as much blood supply, and push them more centrally so that we can perfuse our vital organs a little bit better. The benefit to that is a couple of things. One, we're going to increase our peripheral vascular resistance. So hopefully we're going to increase, by doing that, we're going to increase the perfusion to our vital organs. So by increasing resistance a little bit, we can have better offload of oxygen and nutrients to the organs that matter. So we shunt blood to where it needs to go. The other piece that's important with an increase in peripheral vascular resistance is the ability to increase preload. So we know that there is a benefit to having more blood return to the ventricle, especially a ventricle that is having a challenge with contractility. So if we can increase that preload, we can increase the stretch of the ventricle, and hopefully those myocytes are going to be able to contract a little bit harder in order to get blood out. So that would be that priming the pump kind of piece of it. And then the other piece that we've already talked about is just that shunting of blood to our important or vital organs. So can I push the blood to the places where it should be? With epinephrine, we also see a little bit of dilation in the coronary arteries, which is beneficial because we're going to get a little bit more blood supply to the heart and hopefully a little bit more oxygenation to the heart. So those are some of the reasons why we want to give epinephrine. It's important to remember that epinephrine is metabolized very quickly. So some people consider that epinephrine can be a risk factor for a patient because when we administer it, if we have a ROSC, is the blood pressure going to be too high? Is the heart rate going to be too high? And that's not typically the case because epinephrine is metabolized really quickly by the liver. So typically we're seeing metabolism of epinephrine within 2 to 3 minutes. It's one of the reasons why we're looking at a 4-minute timing of epinephrine in cardiac arrest. So we can be confident that we're not necessarily going to see a ton of those negative consequences because the epinephrine is metabolized so quickly. So now that we've discussed the mechanism of action, we can talk about some of the most recent evidence. So in 2021, a study was published with about 40,000 participants. So this was a retrospective study where they're taking a look at out-hospital cardiac arrest for 40,000 participants. And what they looked at was A, does epinephrine administration make a difference in survival from out-of-hospital cardiac arrest? They're looking at the three core benchmarks. So does it increase the chance of ROSC? Does it increase the chance of 30-day survival? And then does it increase the chance of me being neurologically intact and walking out of the hospital? So do I have neurological survival to discharge? And that piece has been studied over the last couple of years with the earliest evidence coming up in 2018 to suggest that epinephrine does indeed impact all three of those indicators. So when we look at epinephrine administration and the modified Rankin score, so basically what is the likelihood that someone will survive to discharge, that potential increases when that patient has been administered epinephrine in out-of-hospital cardiac arrest. Now, one of the other pieces that we're trying to get to the bottom of, or researchers are trying to get to the bottom of, is does the timing of that administration make a difference? And in 2021, this study that had 40,000 participants also looked at, does timing make a difference? So a couple of important things to think of here, and I'll post this study for you to look at, is they looked at this regardless of presenting rhythm. So regardless if the patient was in a VTAC VF or PEA asystole. We know that patients who are presenting in shockable rhythms tend to have higher outcomes or better outcomes from in out of hospital cardiac arrest. So we don't need to go over that again. But they controlled for that to make sure that that's not what was causing the difference. It's just the fact that the patient was in a shockable rhythm, so they have a higher chance of survival. So they control for that piece, and they look at this timing make a difference in survival to discharge. And again, they're looking at that modified Rankin score. So how likely am I to walk out of the hospital or have neurological survival to discharge? So if my modified Rankin score or my percentage is high, that means that it's very likely. So that's the likelihood of something's going to happen. If the percentage is low, that means it's unlikely or that's not likely to happen. So what they found was when patients received epinephrine, there was basically a decrease, a 5.5% decrease per minute in that modified Rankin score. So the potential for that patient to survive to discharge or survive neurologically intact to discharge if the patient was in a shockable rhythm. So every minute that went past, we started to see a decrease in survival to discharge for patients or 5.5% decrease in survival to discharge for patients who were in a shockable rhythm. When they looked at patients who were in a non-shockable rhythm, we saw the same result. So there was a 4.4% reduction per minute in survival to discharge in those patients for basically the delay. So every minute that went past that epinephrine was not administered, those patients had either a 5.5% reduction in survival to discharge for shockable patients or a 4.4% reduction in survival to discharge for our non-shockable patients. And those were found to be significant findings. So yes, timing does appear to make a difference. This is just one piece of the puzzle, so this is just one study, so there'll have to be a more robust kind of finding or evidence to support this as being fact, but the evidence is getting stronger to support that timing does make a difference. Now, what they looked at was, well, where do patients have the highest level of survival? So where was, in terms of timing, what was the best timing? So what they found was patients who received epinephrine at the 0 to 5 minute mark tended to have the highest potential for survival to discharge, but that result was not significant. So they didn't find that that timing in particular made a significant difference in the patient's potential to survive to discharge. What they did find, or what was significant, was that reduction. So for every minute that went past, we saw either that 5.5% reduction or 4.4% reduction in survival to discharge for patients as epinephrine was delayed. So potentially some evidence to suggest that the 0 to 5 minute mark is going to be what we should aim for. But that being said, it wasn't significant. So we can't say without a doubt you should be giving epinephrine within the first 0 to 5 minutes of the call. What we do know is that we want to get the epinephrine in earlier rather than later. What's interesting about this is not a infallible study. So there are some limitations to this that we have to consider. So for example, the study struggles to control for two important factors. One is that we can't control for how sick the patients are. So they can try to look at downtime, presenting rhythm, but it gets really or a lot more challenging to control for comorbidities that would lead to more delay in access. So do sicker patients simply get a decrease, or we look at having longer access times in patients who are sicker, or do we have more pressing issues in patients who are sicker? So airway management, organization of our team, those types of things. So it's really hard to control for how sick the patient is relate to the time in which I can give epinephrine or the priority of epinephrine administration in the arrest. So that's a pretty big confounding factor. The other piece is it can't control for how well performing the EMS system is. So are we looking at paramedics who have extensive exposure to cardiac arrests, are well trained, who have lots of resources available to them? Because perhaps what we're seeing is just the difference in well-trained paramedics. Well-trained, effective paramedics can gain access earlier, give epinephrine earlier. So maybe it's the fact that they just do their job better, which leads to increased potential for survival rather than simply the ability to give the epinephrine faster. So maybe it's just a better performing team can get epinephrine in quicker, and that's the confounding piece. So those are two pretty big confounding factors that we have to consider, and it's one of the reasons why the evidence is not particularly strong. We'd have to see extensive replication before this is going to be implemented into our guidelines. That being said, we know epi makes a difference. That has been confirmed, is that epi does make a difference. Now we really need to think is, does the timing make a difference? And there seems to be some evidence to suggest that it does. When we want to administer it, that's still up in the air. But we know from our perspective in terms of priority management, there's a couple implications here. One is that we know epinephrine is important, and it looks like the time that we administer it is too. So we want to prioritize it high. We want to make sure that we are prioritizing gaining access and that we are prioritizing the administration of epinephrine as early as possible to these patients in our priority management plan. The other piece is that means we need to consider our route for administration. So do I have the ability to adequately or easily gain IV access? How long will it take me, or how long do I think it's going to take me to gain IV access? How likely am I going to have first pass success in this IV? Because we know that IV is the ideal route. So we see much better outcomes when the medications are given through the IV. So the IV route is better for effectiveness and does tend to have an impact on outcome. So I want to give it intravenous. But that being said, I also don't want to have significant delays. So, if I look at a patient who I don't think can get the IV, I miss 2 IVs, I'm now 14 minutes into this call. Well, when epinephrine delivery makes a difference, I need to start considering what route can I get? What route can I get in a reasonable amount of time in order to administer this epinephrine? So something to consider is not just, how am I going to give it, but we have to start thinking about what route can I adequately achieve within a reasonable time frame, especially if we know that it's likely that epinephrine or timing of epinephrine administration makes a difference. So if you not only think about, I know I want to give it, I want to prioritize it high, but what route can I effectively get? What is going to be the time difference between my IV and my IO? Which one can I get more adequately? So those are certain things that we have to consider here as well. Next, what we want to talk about is intubation. So we'll cover a little bit of, well, when do I decide to intubate the patient, or how do I decide about how I'm going to manage a patient with an advanced airway? One of the other things I'd like to talk about is deciding when to intubate. So how do we decide when to intubate? And I mean, even simpler than that, how are we deciding whether we want to place an advanced airway? So we know, and we're going to talk about specifically cardiac arrest in this case. So what we're talking about here is going to apply specifically to cardiac arrest, but it can transfer over to other pieces. The reason why I say that it particularly relates to cardiac arrest is we know that advanced airway placement in the context of cardiac arrest tends to be associated with lower outcomes from out-of-hospital cardiac arrest. So when we look at advanced airway placement, typically what we're seeing is decreased incidence of ROSC, decreased incidence of 30-day survival following out-of-hospital cardiac arrest, and then we're actually seeing a reduction in survival to discharge or neurological survival to discharge for patients who've experienced out-of-hospital cardiac arrest. So we want to be really cautious with advanced airway management because we know that typically it's associated with more negative outcomes. So when we're deciding to place an advanced airway, it should be based on sound evidence. If the patient doesn't need it, then we are inherently increasing the risk of the patient for truly no benefit. This goes along with the evidence that's out there that suggests that BLS measures are more effective. So that's one of the reasons why when we look straight up here at the beginning of this flowchart is if the patient can be effectively managed with BLS procedures, then there's very little evidence to support movement to an advanced airway, because that movement to advanced airway often leads to more negative outcomes or increased morbidity and mortality. So just keep that in mind. That's the piece that we're going to continue to come back to, is that BLS measures are better when they're working and when nothing else is required and there's no evidence to support anything else being required. So let's walk through this flowchart. So the first thing that you want to consider is, are your BLS measures effective? And when we look at what does effectiveness of BLS measures mean, a lot of the evidence suggests that we're not talking about, can I simply ventilate? So can I put the mask on the face and squeeze the bag? We're talking about is very effective BLS measures. So I'm ensuring that I have a good seal, that I have adequate chest rise, my volumes are reasonable, that my Untitled and SpO2 are reflecting that I have good ventilations. I don't have any rescuer fatigue. So this isn't just a, can I ventilate the patient with BLS measures? So there's nothing indicating I need an advanced airway. It is, can I do it well, and am I continuing to do it well? So that is first and foremost, is if you're going to be making these decisions, you need to determine, are BLS measures effective? And that's not as simple as, can we just put the mask on the patient's face and ventilate? You need to actually do thorough and good assessments for what would indicate that someone has good BLS measures. So we're going to walk down the right side of this flowchart first. So if BLS measures are effective, so we say yes, BLS measures are effective. The next question we have to ask ourselves is, does patient pathology support intubation? So is there something about our working diagnosis that, despite the fact that BLS measures are working, would indicate that maybe an intubation, and we're not talking about an LMA or iGel here, so we're talking specifically about intubation. So if BLS measures are effective, there really would be no reason for me to move straight to an iGel for this patient, but maybe there's a reason why I need to consider intubation regardless of the effectiveness of this BLS measure. So I need to ask, does patient pathology support intubation? And there's a few things in our evidence that would lead us to believe that the patient pathology supports intubation. The first one's pretty easy. So is there a patient subset that suggests that out-of-hospital or pre-hospital intubation leads to more positive outcomes for those patients? For example, one of those patients are patients with TBI or traumatic brain injury. There is some fairly reasonable evidence out there that suggests that these patients benefit from pre-hospital intubation. So maybe my BLS measures are effective, but I have some evidence that suggests that I should be considering intubation. Not that I need to intubate the patient, but I should at least be considering it. The other piece would be, do I need precision in my ventilations? And what I mean by that are, do I need some precise volume or pressure control, or do I have concerns with volume and pressure? The reason why I put this in here is because BVM ventilations, especially in untrained rescuers or less skilled rescuers, so if we're thinking about maybe the fire department is ventilating this patient and hasn't had as much practice with it, or even if we're ventilating and we're not being as mindful, BVM ventilations can cause a fairly significant increase in peak pressure, or we can see an increase in peak pressure with BVM ventilations. What that means is at the peak of inspiration, or when I get to that high point of inspiration, what we're seeing is the pressure can be very high before we get to expiration. So that peak pressure can be really high. Why that's important is that when I have a patient intubated, I'm less likely to get significant leak or loss of volume when peak pressures rise compared to ventilation with BLS measures alone or ventilation with an iGel placed. For example, the iGel, if peak pressures surpass 25 millimeters of mercury, so if our peak pressures are going to surpass 25 millimeters of mercury, we actually start to see more leakage out of the seal from the iGel compared to the endotracheal tube. So we have to start thinking about that is, do I have patients who my peak pressure may be higher? I'm thinking about the asthmatic patient, someone who has air trapping, for the COPD patient potentially, looking at someone who maybe has a pneumothorax. So we need to be considerate of are my peak pressures higher? So do I have a pathology that indicates that the patient may have a higher peak pressure? And if that's the case, BLS measures or a iGel may not be sufficient for this patient because I can see a lot of leakage. With an eye gel, I can see lots of air leaking out of the eye gel as peak pressures rise, so I'm not getting as good of volume as I'm looking for the patient. Or if I have BLS measures and those peak pressures rise, or we start to see a peak pressure of over 20 millimeters of mercury, what can happen is the esophageal sphincter can open and we get more gastric insufflation. So you have to really start thinking about, what is the pathology of this patient? Are the pressures likely to be very high? Do I need to manage that pressure effectively? If that's the case, maybe I should be considering intubation here, because I will be able to more precisely manage pressure and volume for that patient. So you have to start thinking about, do I need a lot of precision in my ventilations? The other patient population that you could think of is, am I getting good, precise volume and rate in the head injury patient? So if I'm looking to hyperventilate someone, for example, can I do that well with BVM or an iGel in place? Or do I need the patient intubated in order to have really precise control over my inspiration, expiration, and rate of ventilation? So even if BLS measures are effective, you want to start asking yourself, what is the patient pathology, and does the pathology support intubation? And like we've mentioned, the first two things you need to think about is there evidence to support intubation of these patients? So evidence says that out-of-hospital intubation or pre-hospital intubation of these patients is better. Do I need precision in my ventilations? So do my rates, volumes, or pressures indicate that intubation would be more effective or more beneficial for this patient? And finally, and probably the easier one, is, does the patient require deep suction or airway control? So even if BLS measures are effective, if you've indicated that this patient is going to need or is at very high risk of aspiration, then intubation would be more ideal. Or if we have evidence that the patient is going to require deep suction in order to correct a VQ mismatch, then we're going to move towards intubation. So if you answer yes to these questions, so if you're thinking about these things for a patient and you answer yes, that's when we start considering intubation when clinically appropriate. Remember, we're talking about someone who BLS measures are currently effective, so I need to think about, well, when am I prioritizing this intubation? So it's not that I have to do it immediately, it's that I'm going to insert that into my care plan and I'm going to prioritize it effectively based on the other needs of the patient. The other alternative is that we say no. So the patient pathology does not support intubation. So BLS measures are effective. We don't have a pathology that supports intubation. Then we would just continue with our BLS measures and reassess. And the important part, or why I include this reassess in here, is because maybe the context of the call changes. So the context of the call changes, but BLS measures are still effective. Well, even if that's the case, perhaps I want to consider advanced airway. And we talked a lot about this in class. One of those reasons would be for transport. So we're going to extricate or transport the patient. We recognize that BLS measures, although they're effective now, will not be effective during extrication and transport. So I should be moving towards advanced airway. And again, I'm not doing that until I'm actually going to move towards extrication and transport. So I'm doing that right before the context of the call changes. When that's the case, so the context of the call changes, but BLS measures are still effective, remember, we've already decided that there's no pathology that supports intubation. Then what we're going to do is we're going to consider practitioner factors to decide which advanced airway am I going to place. So we're going to think about the skill of the practitioner, the resources. So maybe there's a PCP at the head and there's no need for intubation. We can go ahead and place that iGel. Ease. So if you're looking at someone that you think, this is going to be a really hard intubation, I have no pathology that supports the need for intubation, I'm going to place an iGel. Skill level, again, is, I don't think I can get this intubation. I don't need it for any reason. There's nothing about this patient that really indicates that intubation is absolutely necessary. So I'll place the iGel instead. And then first pass success is another thing that I would start considering. So what is my potential for first pass success on this patient? So, is their Mallampati really poor? Is there structural or comorbid factors that are potentially going to lead to a poor potential for first pass success in this intubation or for iGel insertion? So one of those things are something we're going to consider as well to decide what is my advanced airway strategy. So that's if we kind of went down the whole right side of this flowchart of BLS measures are effective, but there may be some pathology that supports intubation specifically, or the context of the call changes eventually, and I need to consider an advanced airway strategy, whether that's iGel or intubation. If we go down the left part of this flowchart, we're talking about someone whose BLS measures are ineffective. So if we're saying, I can't get a good seal, I can't get good chest rise and fall, my BLS providers are too fatigued at the airway, and we need to quickly move to something else in order to continue with good ventilations. So BLS measures are ineffective. Then we're going to ask ourselves a very similar question over here is, do we have the need for precise ventilations or airway control? So is there a patient pathology? So, do we have one of these things that's indicating we need precise control? Do we need deep suction? Do we need to prevent aspiration? If any of the question or the answers to those questions are yes, then we're going to consider intubation when clinically appropriate. So really, if BLS measures are ineffective, I'm asking a lot of the same questions I am over here. Is intubation absolutely necessary for this patient? Do I need to deep suction them? Do I need airway control to prevent aspiration? Or are they experiencing a pathology that the evidence suggests intubation is effective, or that I need precision ventilations? So you're going to make that decision based on the patient itself. So if the answer is yes, then we will consider intubation when clinically appropriate. If the answer is no, so we have no need for airway control, we don't need precision in our ventilations, there's no evidence to suggest that intubation is necessary on this patient, we go down the other pathway here as well. So we just look at practitioner factors. So skill level, resources, the likelihood of first pass success is going to make our decision between iGel and intubation. You can see here in this case, it's not a what do I prefer to do, it's more what am I going to be more successful at doing, and we have to really consider that. So that's the decision-making tree that I use when I'm considering to intubate, and that would be the justification, the rationale that I'd like to see you implementing on calls when you're making that decision of, am I going to intubate this patient?